Hi, everybody. Good afternoon. This is Jennifer Kovich-Bordenick with the eHealth Initiative, and we're delighted that you could join us today. Welcome. It's about 2 o'clock, so we're going to go ahead and get started with a few housekeeping items. While the rest of the attendees are signing on, we've got a number of people joining us today, so we're going to give them a few moments. But delighted you could join us today for our review of our survey findings from the state of patient matching in America. And we've got some really exciting survey results, so welcome today. I'm really delighted that we have such a fantastic panel, and we're going to go through the results today, hear a little bit about some of the issues happening in the field, and then we're going to wrap up. Really, the last part of the session today is going to be a discussion with a really stellar group that we've got here today. So myself, Vitali, who is the VP of Strategy at Nextgate, Dr. Shaun, who's the Vice President for Data and Analytics at Regenstrief Institute, and our brand new, I'm delighted to introduce Assistant Vice President of Policy, Ms. Catherine Pugh is joining us today as well. So after we get through all of the results, we're going to round back up everybody, and we'll get through your questions. So I want to go to the next slide, Claudia, and the next slide. Great. So everybody's muted right now, but this is when we want you to start asking questions, and there's a Q&A box at the very bottom of your screen there. You see there's a big Q. It looks like a file. That box is where we want you to start. Go ahead and plugging in your questions. So as we go through the presentation and the results, put as many questions as you can in there, and we're going to get to them at the end. So please put that in the Q&A box. There's also a chat box down there that says chat, C-H-A-T, and you can see that. That box is really for technical difficulties. So if you can't hear, if your computer crashes, whatever it might be, any kind of technical difficulties, go ahead and respond in that chat box, and we'll see if we can help you. And we've already started getting the questions about the presentation slides. The presentation slides, everything from today is available on our website, and there is a link there. And we'll also send out a link, Ali or Claudia, perhaps we could send the link out through the chat box as well, so folks can pull down the slides later today. That would be really helpful. Oh, there you go, Ali. Great. Thank you for doing that. All right. See, we've got a great team here at eHigh. All right, so let me go over a couple items about eHealth Initiative. For most of you, hopefully know who we are, but if you don't, we are the industry leader convening executives, multi-stakeholder across the industry, and we identify best practices to transform healthcare. And this is all about the technology and innovation that's out there in the world today and how we can really use that to improve healthcare. Next slide. We're really delighted. We've got an incredible group of leaders who really lead the efforts and the strategy and help us figure out kind of all those key issues. And this is just a sampling of some of the organizations that are part of that leadership that take us through and help us figure out what to do. We're always adding people to our leadership, so if this is something that you're interested in, if you're a strategic person and would like to get involved, please let us know. Next slide. Next slide. Okay, so we are focused on a number of key areas this year for 2020, and these are our areas of focus: value-based care, interoperability, privacy and security, and analytics. And you can see here underneath each of these areas are some of the more specific topics that we address in our educational programs and our executive roundtables. If any of these are areas that are of interest to you, we would love to have you come join us or participate in one of our events, or in our webinars or educational programs, or on Capitol Hill for one of our briefings. So I really encourage you to do that as well. Next slide. And we've got our eHealth Resource Center, which is located online. There's a whole slew of best practices, reports, surveys, policy briefings, comment letters, all available in all of these different key areas, which we would love to have you, and they're all free. So you can go there, you can download reports. This report is now available there as well, and if you have a report that your organization has put out, we welcome you to upload that to the Resource Center as well. We're all about creating a forum to share and disseminate information. Next slide. Oh, that slide keeps coming up. Okay, here we go, methodology. So let's get right to the results here. So methodology. So we did a survey last year, July through September, and we surveyed leaders at provider and HIE organizations. And I just want to stress, this is not a scientific survey. This is really just a snapshot of what the industry told us about patient matching. We had about 118 respondents, and the survey was fairly long, actually. It was about 20 multiple choice questions, but they were fairly complex. So this took a little while. So we do appreciate everybody who took the time to fill out the survey. Next slide. And just to give you a sense of who's responded, so when you see these results today, you understand who we're talking about. About 64% were providers, 34% were HIEs, and 2% were similar groups, but didn't quite fit exactly into one of those two categories. Next slide. Okay. We also asked folks, because everybody wants to know kind of who was this? Was this somebody in the C-suite or upper middle manager? And you can see the breakdown here. It was about a third were C-level folks, about a third were upper middle manager, and about 26% said they were director level. So if that gives you a sense of who was filling out the survey, excuse me. Go ahead. Next slide. Okay. So some of the key findings from the report, really interesting, and we're going to go through these in some more detail. The healthcare provider and HIE executives really talked about the data entry errors were kind of the leading cause of their organization's duplicate medical records. And this is really important because we hear about duplicate medical records all the time. So the fact that this is, leading back to patient matching and the data entry point, actually starting at the very beginning. I think we always hear garbage in, garbage out. I think, is reflective of, this is true. This is where these duplicative medical records are coming from, and it's happening at the point of entry. So that was an interesting finding. The lack of funding and staff, we heard, were the biggest barriers to improving patient matching rates at HIEs. And then the lack of prioritization and technology were the greatest obstacles at the for provider organizations. So slightly different challenges being faced by the HIEs versus the providers in terms of patient matching. The third key finding was that a large majority of the HIEs and providers actually have dedicated employees that go through and resolve the duplicates and mismatches, and that they go through these records on a daily or a weekly basis, but they do have staff. There was actually a high average of support among HIE and healthcare providers for the federal government to mandate a nationwide patient matching strategy, and we'll talk about this a little bit more as we go through the program today, to provide funding. And we hear a lot about this on Capitol Hill and whether or not we should have a mandate here or some kind of federal program to help support this, and there was definitely a support for that among the HIEs and providers. And then we also asked about innovation, and both the providers and the HIE executives really thought that data standardization and biometrics was a very promising innovation that could really help promote and impact the matching efforts across the nation. So this is just kind of a high-level look at some of the key findings, and we're going to move on and get into some of the nitty-gritty detail, but again, if you would like a copy of those slides, they are available online, so I encourage you to pull those down, and we'll make those available to you. So let's dive into the poor patient matching piece of the results. So in terms of what actually contributes to poor patient matching, so about 66% said data entry errors that happened at the point of data entry. About 46% thought it was poor algorithms, and 42% said it led back to that lack of integration and that whole interoperability issue that we are always talking about. So all really big contributors, but for the most part, again, I think data entry was the largest there. Next slide. Some of the biggest barriers to improving patient matching rates, again, lack of prioritization, 41%, lack of technology, 41%, and lack of data governance was at 30%. I don't think any of these are any surprise to any folks on the phone, but just kind of stress what we all, I think, know to be true, which is that this is not always a big priority for organizations. Everybody doesn't have the technology and the governance in place that they need. Next slide. So we know there's a problem, we know there are barriers to it, so how do we go ahead and measure and address the duplicates? Let's talk about what we found out here. Next slide. So first of all, we asked groups what percentage of all their records at their organizations were duplicates, and you can see here kind of the overall breakdown, which I don't know if that's as helpful as looking at the HIEs versus the providers separately. A lot of data here to look at on this slide, but you can see for the most part, less than 3 to 10% makes up the majority for both providers and HIEs. About half or over half of the organizations are 10 or less % are duplicates. So we're looking at, again, less than 10% are duplicates at most organizations, about half of the organizations. Next slide. Are there dedicated employees or contractors to resolving potential duplicates or mismatches? So at HIEs, there are about 85% said yes, they do have employees, and provider organizations, about 3/4 of them have employees that are dedicated to just resolving these issues for their organization. So it looks like the HIEs are staffed a bit better than the provider groups right now. Next slide. We did want to get a sense of how many employees or contractors are employed to address potential mismatches. This data is a little bit harder to follow because without kind of knowing how large the organizations are or how many records they're dealing with, it's kind of difficult to assess here, but this is, so let's move on, Claudia, to the next slide there. Okay. So how often do employees or contractors address potential mismatches? And I think this is important because this really gets at how big of a problem is this for organizations, for both HIEs and providers. And I think you can see here, you know, about half the organizations, 47% of HIEs, 56% of providers are doing this on a daily basis. So this is what people do. Their job is basically to go through these potential mismatches and fix them. And I think that that really shows that this is a fairly resource-intensive, laborious issue to deal with and a real problem across the spectrum of healthcare. Next slide. So we're going to talk a little bit about quality assurance and patient safety. Okay, so we asked the hospital and the provider groups what adverse events related to this poor patient matching? And we also asked providers about quality assurance protocols kind of surrounding patient registration. Particularly, first we asked, has your organization had an adverse event due to patient matching sometime in the last 2 years? About 38% said yes, 38% said no, and about 24% were not sure. So it looks like maybe about a third were aware of something happening in the last 2 years related to patient matching. We also asked if there was a QA or quality assurance step during or post-patient registration to look for discrepancies and demographic or insurance errors, really to look for that patient matching, you know, trying to get ahead of the problem and make sure it wasn't there. And about 67%, or about 2/3, said yes, there is a QA step in place to do that. And I think that that's hopefully reassuring, but only for about 2/3 of patients that that is taking place. So that's still a little worrisome. Next slide. So in terms of, again, looking at the data, you know, what role does patient matching and quality metrics play in your organization? And I thought this was interesting as well. You know, about 10, 11% said that they haven't even considered the use of patient matching in terms of a quality metric. So whether or not this is happening is not used by many of them. About 21% said they've started planning for the future capture of quality metrics. And about a quarter said that actually quality metrics were in place with data definitions for each metric. So this isn't quite a number that people are using on a regular basis yet to track their performance and assess the quality of care there, which is, I think, a bit surprising that this isn't a solid quality metric. You would think making sure that you've got the right person and the right information in front of you would be a little more of an imperative. Next slide. Okay, so the last part here is the patient matching and EHRs, electronic health records. Okay, so this is where we were asking organizations how many systems you actually have currently right now in your IT environment, and this varied greatly, anywhere from 1 to over 31 systems in place. So just to give you a sense that there was a pretty wide variety in terms of the organizations that were responding. Many of these organizations have very few systems, less than 5 systems that they're trying to interface and deal with interoperability issues. But there are a fair percentage that have, you know, a couple of dozen different IT systems that they're trying to use together. Next one. So on average, what percentage of your master patient index total patient population is your potential match backlog? And this was kind of a really interesting question, I think, in terms of, you know, how big, again, of an issue is this? And that whole backlog of making sure that you're checking everything and that you're up to date is important. And the backlog was less than 3% for about a quarter of the HIEs, and less than 3% for about for 20% of the providers. So overall, about 20% said that the backlog was less than 3% of an issue. The fact that it was more than 50% of an issue, I think, for about such a smaller percentage, 4%, is probably not great, but it looks like the most of the group was kind of right in there in between 3 and 50%. So just to give you a sense of what the backlog is currently for this group. Next slide. Okay, and the government's role here, and I think we're going to get into this policy discussion a little bit more after Shaun presents as well, but should a nationwide patient matching strategy be implemented? 31% agree completely, 39% agreed a little bit, and there was a much smaller percentage, 4% disagreed completely, 11% disagreed somewhat. So I would say overall, you know, you've got about 2/3, a little more than 2/3 of the group really leaning towards a patient matching strategy nationwide. And then there's always the issue of federal funding, and should that be made available to create a US Patient Identifier? And I think that this, again, is a little bit all over the place in terms of agreeing somewhat or agreeing completely. About a little more than 2/3 agree, either somewhat or completely, that the government should fund this. And that will get into all sorts of issues of what that might look like and how that might be rolled out and come into play. But there's certainly a lot of agreement there for the governments, the feds, to take a greater role here and fund something to help alleviate this issue. Okay, and future trends. Keep going. All right, and some of the innovations most likely to impact patient matching efforts. So we asked folks on a scale of 1 to 8, with 8 being most important. The provider and HIE leaders were asked to rate various innovations and whether or not they thought that would really help with patient matching efforts. And what we found was that overall demographic data standardization and biometrics were really ranked the highest in terms of innovations that people thought would help with patient matching. Which I think is great. I think we all know those are really exciting innovations. And then third-party data and machine learning came in slightly behind there. But I think we're all aware that these are really some exciting innovations, and we're hoping that hopefully that will help alleviate some of the issues here with matching. Next slide. Okay. So I'm going to take a breath here, and we've got lots more data coming from actually Dr. Shaun Grannis, who many of you know from Regenstrief, professor of medical informatics there, and he's going to go through some additional data and talk about the national strategy, and then we will wrap up with some questions at the end with Vince. So Shaun, I'm going to turn it over to you.
Great, thank you, and thanks for the opportunity to speak today. So I'm going to add a little bit of color and context to the data standardization piece with some of the work that we've done in conjunction with Pew, bringing some evidence to this field. Why don't we go to the next slide? So, so there's been a lot of matching recommendations over the years. I'm sure that many of the people involved in this conference and listening in have participated in expert panels and subject matter expert recommendations. Go ahead and sort of click through here, keep going. These are just some examples of recommendations over the years that people have made. Keep going. That was the eHealth Initiative one right there. They were part of that. So Bipartisan Policy Center. I think there might be one more, maybe not. Okay, there we go. And so through all of these, there have been a number of recommendations made, some very wise, sound recommendations, but the reality was, believe it or not, one of the recommendations has been all through the years, data standardization should make sense. It just makes obvious sense. If we clean up the data, if we provide better fuel to that matching engine, the matching engine should work better. Everybody agreed on that, but there actually has been almost no research in that space to show that, and the degree to which standardization makes a difference, and which fields standardize everything, some things. So we worked with the Pew Charitable Trust to look at standardization using some real world data sets. Why don't we go to the next slide? Oh, keep going. That was the last one there. So we looked at some recommendations that have come out of these reports. For last name, we looked at the CAQH Core 258 that talked about how to normalize last name. We looked at standardizing telephone numbers. We looked at standardizing address using the United States Postal Service address formatting recommendations. We looked at cleaning up Social Security number using rules recommended from the Social Security Administration, and then standardizing date of birth as well. So those were the types of standardizations we looked at in our study. Go ahead, next slide. And so we used 4 different data sets. So we looked across different matching use cases because there are different matching challenges when you look at different contexts within the healthcare system. So we looked at linking newborn birth data to newborn screening records. So being able to identify early on patients who lack newborn screening is an important topic, and we used that context to study newborn linkage. We looked at linking public health registry data to clinical data and deduplicating that information. Public health departments often lack significant resources to maintain high quality data, and we wanted to understand how linkage worked there. We looked at linking clinical data to the Social Security death master file. So understanding who within a given clinical record is deceased is very important, helps to improve data quality, helps to improve understanding of clinical outcomes, et cetera. And then we did the bread and butter linkage, which is what most of us think about when we're thinking about patient matching and linkage, which is linking clinical system to clinical system. It says hospital to hospital here, but it's actually healthcare organizations to healthcare organizations. So those were the 4 data sets that we applied those 5 data standardization rules to. And why don't we go to the next slide? So I'm going to jump right into results. We looked at all possible combinations. So if we have 5 fields that we're going to standardize, we have about 8 fields, 5 different standardization methods. So we actually had hundreds of different combinations that we looked at. It turns out when we look at standardization in the HIE linkage use case, it turns out that standardizing last name and standardizing address made a difference individually. And on this slide, you can see the sensitivity graph. If you look across the bottom, you see something called add, which is address. And you see an almost 5 percentage point improvement in match sensitivity or true positive rate by standardizing address. You also see for last name about a 1.5–2% improvement in match rate as well. So those were some of the significant findings. Those 2 fields, by the way, were the only fields that we saw in our data sets that actually improved overall matching accuracy. Why don't we go on to the next slide? So those were the individual fields. If we just standardized one field, what was the match improvement? Then we looked at combinations of fields. And it turns out when you both standardize last name and address together, you actually get a synergistic effect. So what we see here on match sensitivity, if we standardize only last name, if we look at that leftmost sensitivity graph again, standardizing only last name or address only produces the 2% or the 5% that I mentioned. And then when we go to when we combine both of them, we actually get a synergistic result. We actually get more improvement than the sum of both of the individual results. And there are reasons behind that that I can go into. It relates to the algorithm and how the algorithm gets parameterized as a result. But the bottom line is there is clear evidence that standardization makes a significant difference. Address, which is this free text field that often people are typing in, tends to be a longer field, and it tends to be more opportunity for those data errors that Jennifer mentioned early on. And so standardization clearly makes a difference. Now, is this deeply profound? No, these recommendations have been made over and over again. What we've done here, I tell people, is we've measured the mass of the electron. We knew, physicists long before they knew the mass of the electron, they knew it had some mass, just didn't know what it is. Well, here we've shown, we know that standardization has some impact. What is it? Well, in this case, we see some pretty substantial improvements in match rates for the bread and butter clinical linkage use case. So that's some of the evidence that we provided. We're actually doing some additional work now that we hope to get published over the next 6 to 9 months, supported by PCORI and by AHRQ. But so more to come, but we certainly are starting to get some clear evidence. As a result of this, we've been working with Pew to encourage organizations like ONCs and the vendors to ensure that they have standardization approaches for address and thinking about that for last name. So getting that acculturated and built into these systems, we think will be important moving forward. Now I'm going to move from evidence and research to talking a bit about national policy. Go ahead and click once again. So the appropriations text that was approved last year actually had a paragraph, some rider language related to patient matching, and I've provided the reference to that specific document here on the slide. Why don't we go to the, well, actually, before we go to the next slide, why don't we hold up? So, by way of background, long ago, shortly after the HIPAA regulation came out, and HIPAA enabled, encouraged the development of a national unique patient identifier. All funding for the development of a national unique patient identifier was restricted by Congress. So for over 2 decades, or nearly 2 decades, we've had a restriction on funding, so no progress has been made on this very important aspect of our healthcare infrastructure. We standardize provider, we standardize facilities, we standardize vocabularies. We do not standardize the patient today. It is a gaping hole in our e-health infrastructure. So this year, we're seeing some incremental movement. Go ahead and click again. So this language calls on, the appropriation language calls on ONC to develop a report over the next year. Go ahead and click again. And in that report, ONC may make recommendations regarding a unique patient health identifier. Now it says may or may not, so there's some wiggle room there, but we now have language in the appropriations bill that says we can start talking about a national identification strategy. So while this might be a small step, I think this is going to have significant implications for the national conversation that we need to start having. Whether it's a unique patient identifier or whether that national strategy includes other components, we just have to start asking and answering the question. So I'm very excited about this language. I'm very excited about the attention being given to this topic at this point. And I think that ends my slide deck. So looking forward to the dialogue. Thank you.
Thanks, Shaun. Great. Well, we just went through a lot of data. So I think we're going to take a moment and talk about what we just went through here. First, though, I just wanted some kind of general impressions. And Vince, why don't we start with you, because this is kind of your bread and butter, I think, what you deal with day in and day out. So what did you think about the survey results, Vince? Anything surprising?
Yeah, thanks, Jennifer. I don't know that there was a lot of surprises, but I do think it validated a lot of things that we figured we knew or we thought we knew. I am kind of disturbed, and I hope everybody's disturbed, that 38% of sites said that they had some sort of adverse event related to patient matching in the last 2 years. I mean, that's just, I mean, really, just think about that in the context of other industries, and it's just unacceptable. I mean, I think we all can agree to that. So the question becomes, how do we deal with it, or what do we do about it? I was also interested in some of the numbers around duplicate error rates, because I think a lot of institutions measure that out of their core EHR. So if they have Cerner, Epic, Meditech, they're looking at that core system and trying to determine what their duplicate error, patient record rate is. But you got to really look a little bit broader than that. And I think most sites kind of lose sight of that. But the other slide that talked about the number of EHRs in your system, we see on average about 15 to 17 different EMRs or EHRs within a health system. And if you look across all 15 or 17 EMRs, then your patient duplicate rate becomes a little bit more realistic. And I think if you're measuring, you want to be careful not to measure just one system, even if it's your core system, because those duplicate records proliferate throughout the system. And when you talk about the duplicate error rate across systems, between hospitals or between hospitals and other entities, that rate goes up considerably. So I think it's a little misleading to think that the duplicate rate is as low as it is in some cases, but certainly it's an area that we need to obviously focus on and understand better.
Yeah, can you explain, Vince, what duplicate means? We actually had a question from someone in the audience about what we mean by duplicate. Like if a patient, can you explain that for folks?
Sure. Well, what happens, of course, and just for myself, if I'm registered as Vince Vitali within one application in a health system, but I'm registered as Vincent Vitali in another, and Vincent S. Vitali in a third, you can see where there's multiple records that can be created. So there might be health data, my health data, associated with each of those different names. So it could be duplicate, it actually could be triplicate, and we've worked on cleanup efforts at MPIs, at larger health systems, where we found up to 6, 7, or 8 different versions of a single record. So data can be fragmented. So when we say duplicate, we don't just mean binary. It could be multiple fragmented records or variations on a single record, and data associated with each one.
Wow. Well, let me just follow up on that, just because I can tell by some of the questions we're getting in here that not everybody's as familiar with patient matching as this group. But so one person is asking, well, can't you just verify someone's address and spelling during the intake? So it sounds like we need to explain a little bit more about why it's not just as simple as making sure the information's right when you admit them or take them in.
Well,
can you explain that?
Well, that's one. Yeah, that's one. I mean, that's one of the areas, I guess, that showed up in the survey as being one of the largest sources of error, which is the entry or the data source that happens at registration. And yes, you can ask people to verify their name and address. It's not always asked. If it's asked, sometimes it just might be a simple matter of miskeying the information given. And also, one of the things that Shaun talked about was address verification and standardization. And someone gives you an address and you type in 14 Mitchell Street, and sometimes you put ST and sometimes you put STREET. If there's an apartment number involved, it could be a pound sign, or it could be number, or it could be just the number itself. I mean, so even if you ask somebody what their address is, they can tell you what it is, but 3 different people input it 3 different ways. And so if you don't have standardization from a input perspective, and that's more policy related to the individual organization, and also matching that address, like Shaun talked about, matching it to a U.S. Postal Service standard, then it becomes a little bit, it becomes more discrete. So it sounds simple, but it doesn't happen. And think of situations like the emergency room, where people are under fire. It's very fast-paced, lives at stake, etc. You're not really worried too much about getting the patient's address right. You might be worried about just getting the patient in to see the physician as quickly as possible. So sometimes people will cut corners on that process, and oftentimes it has results on the back end that are not as anticipated.
So I think that's a really important point that you just explained there, because there are a lot of questions about, if it's not just necessarily that it's a data entry error, an error in terms that it's wrong, but that it's entered in different ways. So if somebody says Mitchell Street, as you said, spells out street completely versus just puts ST in, even if you check that at the intake, it could be that it's entered a different way somewhere else, and then that creates a duplicate. So it isn't just as simple as knowing you have the right information, but making sure it's entered consistently across the board. So, because we've gotten several questions about, why can't we just check up front?
Yeah, what about hyphenated names, and what about, different people that use their middle initial or don't? I mean, there's so many different combinations that it becomes very difficult, for people on the registration side to always get it right, and especially across a group of registration. And look at healthcare is expanding, so the number of points of entry within the healthcare system is growing significantly. So where you enter the healthcare system and where you might be registered is ever expanding, and therefore just more sites means more opportunity for error.
Right. So it's not, so we've gotten other questions about, well, how often is this because somebody's name changes or their address changes? It could be that the address, do we have any sense of kind of what the errors are on the front end?
It's all of those things. I mean, those things
Okay.
do happen. I mean, people get married, divorced, et cetera, or just change names. They change addresses because they move, et cetera. Those things change over time. So there has to be a kind of a view of history taken into consideration as to how these things happen, when these things happen, and then you can kind of look to see a pattern, if you will. And it gets back to a lot of the things that you know, EMPIs do, or Enterprise Master Patient Index engines do, is looking at those patterns and trying to determine and decipher what's changed and why. And is it really the same Vince Vitali at 123 Mitchell Street versus, you know, 14 Anderson Drive? You know.
Yep. So, Shaun, I'm going to ask you to jump in here. What were kind of your overall thoughts in terms of the data? Did anything surprise you from the surveys?
Well, I think it reinforces a lot of what we know. Standardization is necessary. We know that people are contributing a significant amount of FTE effort to solving this problem. This is not just a patient safety issue, which is, I think, the most important topic to discuss here, but it's also an inefficiency issue as well. I mean, this is costing millions of dollars a year for many healthcare organizations to manage this, and they're certainly, by improving this strategy, not only can we improve patient safety, but we can also save a lot of money in the healthcare system. So I think these findings are very consistent, and it shows that this is still an issue. I mean, we would hope by now, with all of the investments our government and other organizations are making in the e-health infrastructure of this country, that we would be making a dent in this. But I think we're still facing these issues.
Yeah, definitely. I'm going to turn to Catherine for a second, because Catherine was actually up on the Hill today talking with folks about patient matching, and we've gotten a lot of questions about kind of what's the possibility of Congress approving a national healthcare identifier. Can you speak to that a little bit, Catherine?
Yeah, and I think Shaun gave a pretty good background there, but just wanted to highlight again that Congress doesn't have to approve a national patient identifier. What their appropriations ban has basically said is that HHS is prohibited from using any federal funding to establish a national patient identifier. What most groups have advocated for is removing that ban, not so that Congress can establish or HHS can establish one national unique patient identifier, but that they can start having those conversations with private industry, like Regenstrief and Nextgate, that are looking at these issues and find the best possible solution, whether that's biometrics, standardization of data, machine learning. I don't think that anybody or Congress has any interest in legislating a specific solution, but rather allowing for that conversation to happen. But in terms of removing the ban on the unique patient identifier, I think it's tough. I mean, the House last year passed for the first time an amendment to remove the appropriations on the House side, and on the Senate side, it is interesting to see both from privacy concerns from both Democrats and Republicans. It's not one side versus another, this issue. So you have privacy hawks in both parties that have concerns, and I think the more that we can continue to educate and provide real information, which is why this ONC report that will be coming out in the next year or so will be so important to inform Congress on what the right next steps are.
Yeah, so I mean, just to, again, underline that again, so there's an actual ban on using a national patient or healthcare identifier. So it's not just that we have to pass a law, but we have to get rid of a law in effect just to be able to talk about it. And I think this has been in existence for so long that for a lot of folks who are just kind of in this area in the last few years, it's kind of you know, amazing. They can't understand why you can't even talk about it, I guess.
Yeah, Jennifer?
Yeah.
I was also at that briefing with Catherine this morning, and one of the panelists, Mike Martz, who's from CIO from Mount Nittany Health System in Pennsylvania, made a point that without having a national patient identifier, it's almost harder to protect privacy. And so his point was that the universal patient identifier, or national patient identifier, was actually a good thing to protect privacy, and he was arguing that he couldn't see how you could protect privacy without having one. And so that was kind of an interesting point that he made, and I thought it generated some good discussion.
Yep. So, Shaun, do you want to comment on that at all? I mean, this has been going on for a while, so.
Sure. Yeah. No, I think that was a great overview, and I agree. The goal here is to be able to start the conversation, start the dialogue, and I don't think we should presume at the outset what the right solution is, because I think there are a lot of stakeholders that need to chime into this. You know, whether we standardize our approach to identity management with or without a unique patient ID, we have to do better than what we are doing. And so I'm just excited. What I was so excited about that paragraph in the appropriations language is this is Congress saying, hey, talk about this issue. Give us some advice, some guidance. Let's not, you know, hide this under a bush anymore. Let's bring it out in the open and have the conversation, because I think people are now starting to realize, boy, we really do have an issue here. Without a consistent approach, we're going to continue to face inefficiencies and suboptimal clinical outcomes. So I view this language as a signal that people are beginning to recognize the importance of this issue.
So we've gotten a lot of questions about, well, can't we just use a social security number if we need national patient identifier? Or can't we just use real ID? Or I think, again, this goes back to the issue. I think that people aren't aware that you can't really create, there's a prohibition on spending or funding any kind of creation of a final standard for a national ID or unique ID. So you're not allowed to really even fund it or talk about doing it. So we couldn't just adopt using social security numbers or real ID. We're not allowed to do that.
And even if we were allowed to do it, you know, in our health system, less than 60% of people actually present their social security number. There are duplicates. It wasn't designed to serve that particular purpose. There are some people, you know, the railroads employees don't have a social security number. So there's just a lot of problems with that number outside of the regulatory issues.
Yep. So let's talk a little bit about that. You know, what are some of the main blockers, you know, to adopting a standard for a unique patient health identifier? Is it, you know, kind of a big brother concern or patient privacy? Vince, you've got any thoughts on that?
Yeah, no, exactly. That's the argument on the privacy side, and Catherine was very, very correct about privacy hawks being on both sides of the aisle. There are a lot of people that are very concerned about the government issuing a single identifier and having control of that identifier, and what they will do with that identifier once it's established. So, and also, you know, anytime you concentrate data around a single source, people are going to wonder about how easily is it compromised. So, you know, those are all legitimate concerns, and I think it's something we need to be aware of as we move forward on this journey. And you know, we've been doing it a long time, but I think we're actually starting to make some good strides. I think we just need to keep at it and keep working. One of the things that Shaun just mentioned was also a topic this morning at the briefing, which is we need to start the conversation, but we need to get the right people at the table. You know, and that's a public-private partnership of getting the right stakeholders talking about this and getting the input we need to start moving things forward. So, yeah, so I think privacy is going to continue to be an issue, but it's something we have to address. And we have to look at the other side of it as to what problems are being caused by incorrect patient matching. And I think we know that those are significant. So I think it's just something we just have to figure out.
Yeah, Catherine, anything you want to add to that?
Yeah, those are all great points. And I think one of the one of the things that groups are trying to do, including this, this briefing that Vince and I were at this morning, is educate folks that there are other solutions out there besides the unique patient identifier, and technology has advanced to the point where it can be done and protect patient privacy. And NCPDP presented on their solution that they're working on with Experian Health, which is the unique patient identifier, but it's never surfaced to the patient provider, or if government were to adopt it, it would never be surfaced to any government agency. It's more on the back end where all of the technology is happening without anybody knowing. Everyone has a number, but nobody actually sees it. And they've actually created a number for 100% of the U.S. population. So everyone has a number now through Experian Health and NCPDP and the pharmacy side. And so it's interesting that they're doing that work, and just educating folks that there's other solutions out there that can be secure and can move forward.
Vince, can you talk about, like, we've got questions about what are other organizations using, like probabilistic matching, deterministic matching, like, can you talk a little bit about what some of those other solutions look like?
Sure. You know, the EMPI engines, if you will, have been out there for quite some time and refined and developed over time. So both deterministic, which is more brute force kind of lookups, and probabilistic, which is more intelligence-based algorithms, have been developed and refined, and there are a number of them out there that can be combined and used synergistically. But beyond that, you have the capability to add referential data. Referential data is third-party data sources that are external to the organization that you can kind of compare your data against. And, you know, we find that, you know, in a well-defined data set or good data governance structure in an organization with an EMPI engine can probably get to 95 or even 98% success. You know, it's about good data practices. And then we find that if you want to, of the remaining records that aren't matched, if you bounce them off a referential source, you maybe get 40% of those matched, of the remainder matched. One of the problems with referential data we found is that, of course, for minors, it's really non-existent. There's really not any referential data for minors. It's covered by COPA laws that restrict you from tracking data on minors. And also we see that seniors, as a population ages, they get fewer and fewer entries into the public data sources. So the data starts to trail off at about 55, 60, maybe a little bit over 60 years old. So, you know, so referential data has its use as an add-on capability. It's not a panacea, though. So, and then you talk about things like biometrics and how those fit in. And biometrics, you know, there are a lot of different choices, and trying to create some interoperability between biometrics is also a challenge, whether it's retinal scan, facial recognition, palm scanning, fingerprints. There's a lot of different choices, and if you have to support all of those things as a health system, it can be really costly. And then how do you share that data across health systems when one's using facial and one's using iris and the other one's using palm? You know, so we have to work through some of those things, and although biometrics, you know, present you know, an opportunity, I think there's still a work to be done in that area as well.
Great. Shaun, what do we know about what other countries are doing with national patient identifiers or the matching problem? Do you have any sense of that?
Sure. So we're seeing in many countries, ministries of health are defining strategies sort of in a top-down way, and many countries are thinking about that unique patient identifier and deploying that. But in developing countries, often, you know, there is a cost to that strategy, and so they're still working with those identifiers, those demographics that are readily available. We're starting to see in countries that have public-private relationships that often the private organizations have one approach to matching and the public or government approach uses a different strategy. In most developing countries, the United States is the last developed country without a unique patient ID. I'm not saying that because I think we need one. I'm just making the point to see how other countries have solved this problem. Every country has unique characteristics. Its culture, its politics, its technology, its economy, all factor in to decide what kind of an identity management strategy they're thinking about. People across the world are all worried about identity theft. They're worried about privacy and confidentiality. So all of these factors continue to work together. There is not a one-size-fits-all by any stretch of the imagination. So even though many countries have gone with that national unique patient identifier, making that final decision requires a number of different factors. And so it's not, some of these questions about social security number and why not just use this identifier. The problem has never been about the lack of a unique identifier. It is easy technically to create a unique identifier. From a technical perspective, this is not an issue. It always comes down to that governance. It's the people underneath the technology where we need to develop the governance, the relationships, the expectations of that problem. I work with countries like Rwanda, the Philippines, Kenya, Nigeria, Uganda, and they are all struggling with these issues. And it's not a technical issue. It is very much a social, political, economic issue that people are facing. And the technology is frankly often the easiest part of the issue.
Vince, any comment on that?
Yeah, no, I was, Nextgate actually has a strong presence internationally, and we are actively used in the UK and in Australia, as well as France and the Middle East. And like Shaun says, all those places have a national patient identifier. And the issue is, how does that identifier get proliferated within the systems and applications? How does it get used, and how standardly is it used? So Shaun is absolutely correct. It's more a people problem at that point in time. They've defined the national identifier and thought that was going to solve their issues, but in reality, it hasn't really. They continue to have those issues because they don't have the data governance and structures fully implemented.
Vince, what about what other industries do in this situation? Is there anything we can learn from them, or how are they handling this?
Well, actually, it's interesting. There are things that have been done in like areas like the banking and the airlines, but the problem is that the data is so unique and complex in the healthcare space that it doesn't lend itself easily to an ATM kind of a model or a traveler ID, a trusted traveler ID model. There's very limited information on those systems that need to be tracked and verified. But within the healthcare space, it's a lot more complex.
Mm-hmm. So we've got also questions about, is this something the private sector should come up with the best solution? Do we want the private sector kind of leading the development here?
This is Vince. I'll jump on that one first. I mean, I think it's going to be a public-private sector partnership. That we have to get standards established, and I think the government can help a lot in that regard in helping us create those standards. And support and enforce those standards. But certainly, I think something Shaun said already, I don't think it's a one-size-fits-all. I don't think there's a single solution out there that gets you 100% of what you want. I think there's going to be standards and there's going to be different implementations as long as we're applying the same standards. Different implementations of different technologies that are all going to be synergistically focused on trying to get the best outcome possible as far as patient matching.
Mm-hmm. So Any comments on that, Shaun? I want to give you
Oh, I agree with what Vince had to say. Again, I do not presuppose what the right approach is, but I do think that there are a lot of very smart people in industry and other places thinking about this problem and have a lot to contribute to that to make it work. And so I do think that there's significant opportunity for industry to play an important role in that. And I do like the notion there. How do we set standards? We can have industry work on industry-driven standards. That may work. We may need the government to also assist in that process. So again, I think it's going to be exciting this year to see how ONC approaches this report, who they speak to, how they frame it. And these are all the questions we're talking about today, I think, need to be covered in that report. And so I'm really looking forward to seeing what ONC has to say about all this.
Vince, do you want to make any final comments before we get ready to wrap up?
No, I think the study was very welcome. The survey provided a lot of good information, and I appreciate all the work that EHI did on that. And I think the industry is better for having this information. I think there's a lot more work to do.
Yeah. And I want to thank Nextgate for supporting this important work. It's really difficult to do this kind of work, so we're very grateful for Nextgate's generosity and willingness to explore this topic area and get the word out there about how big challenge this is. So thank you, Nextgate. And we have come to the top of the hour, so we're ready to wrap up here. So I do want to just remind everybody you can get a copy of the slides online. Feel free to go ahead and download those. The link is there. Ali has sent that out. And we welcome any additional questions you have. And thank you again to our panelists today, Vince, Catherine, and Shaun. And thank you again to Nextgate. And we will see everybody on the next webinar. Thanks for joining today.
Thank you.
Bye.
Bye.